Welcome to our PrecisCa tumor board on myeloma. I'm Dan Pollier from the University of Colorado. I'm very excited to be with you today for some really interesting cases. I'd like to have our esteemed panelists introduce themselves, and just maybe starting from left to right, perhaps Dr. Nuka can begin.
Thank you for having me. I'm Ajay Nuka. I'm an associate professor at the Winship Cancer Institute. I am the director of the myeloma program, and I'm the medical director for the Winship Research Informatics Shared Resource.
Hi, I'm Peter Forsberg, also from University of Colorado, an assistant professor out here in the myeloma group with a specialty in myeloma and plasma cell disorders.
Thank you for having me. I'm David Schuster, and I am the director of the Division of Nuclear Medicine and Molecular Imaging at Emory University.
So this is a 60-year-old female with non-secretory multiple myeloma, diagnosed 8 years prior in Mexico after she presented with a cord compression from a T4 plasmacytoma. And for this, he had a surgical decompression, radiation, and then chemotherapy with melphalan, thalidomide, and prednisone. She has not been on maintenance therapy and now presents with a delayed relapse and is currently being evaluated for an autologous stem cell transplant. So we're going to talk about the recommended management for patients, specifically with non-secretory myeloma with a delayed relapse, the optimal way to perform response assessments for such patients, and then to discuss whether a patient such as this should be or could be considered for an autologous stem cell transplant. A little bit more detail about this patient. She presented with right hip and left hip pain, balance issues from multiple back surgeries and a performance status of 3. No contributory medical, social, or family history. And so the patient presented in 2013 with low back pain and was found to have a T4 cord compression. The biopsy did show a plasmacytoma, and she had a decompressive laminectomy and then 20 gray of radiation to the spine. Can I stop right here and just ask Dr. Nuka specifically? I know you're not a neurosurgeon, but you are probably one of the first people called on a patient like this. What's your approach to the sort of urgent management of a patient with this type of pain and plasmacytoma? Are you somebody who recommends surgery, or under what conditions would that be?
Sure. So it is not an uncommon scenario to see this. So the first question that we'd be asking is, what is resulting in the cord compression? So is it a tumor mass? Is it a plasmacytoma that is causing cord compression? And these plasma cells are exquisitely sensitive to radiation initially. So that would be the approach that I would be taking to have the decompression. Whereas if this is resulting in a fracture and the cord compression is happening because of some bony fragments or having the vertebra moving in, causing the cord compression, we don't have a choice other than to go with a decompressive laminectomy.
Great. Okay. Thank you. I know that can sometimes be a little bit of a challenge. So this patient, after having some local therapy, has 4 cycles of melphalan, thalidomide, and prednisone, and has a complete response. No autologous stem cell transplant in that first remission, and was not placed on maintenance therapy, and had multiple years go by with pretty limited follow-up. Recently, a pathologic fracture of the right femur and a left lytic lesion in the left femur requires an open reduction and an internal fixation of the right femur. And at this point, a bone marrow biopsy shows a non-secretory multiple myeloma. There are free light chains, serum immunoglobulins, and serum and urine protein electrophoresis, all which are normal. And so perhaps we can first jump ahead to the imaging with Dr. Schuster of the hip.
Yeah, so this is the left hip, and we could see in the intertrochanteric region a lytic lesion. And this is only one of her lesions, that we've seen from the text. She's already undergone open reduction internal fixation of the right. She's had the T4 lesion, et cetera.
Thank you. So first, maybe Dr. Forsberg, can you just take us through the diagnostic entity that is non-secretory myeloma?
Sure. Essentially, non-secretory myeloma is myeloma, systemic disease. Not necessarily something like an isolated plasmacytoma, but a myeloma that fulfills other diagnostic criteria with things like marrow involvement and plasmacytoma or multifocal plasmacytomas, but that doesn't create a monoclonal protein that's measurable. So essentially, you don't have a consistently or adequately measurable monoclonal protein or serum-free light chain abnormality, both or either in the serum or urine, that allows for disease that can be routinely measured and quantified. So I think that it's a challenging scenario in terms of it doesn't give us our routine biomarker to monitor disease. We live in the realm of myeloma. Most of our response assessments, most of our disease monitoring occurs primarily via serological assessments to measure monoclonal proteins or serum-free light chain abnormalities, and that allows us to evaluate how well our treatment's working. It allows us to identify loss of disease control prior to symptomatic development, oftentimes. And so, non-secretory myeloma, is primarily an entity of a measurement problem. It's not necessarily, there's not as many biological differences between non-secretory myeloma and regular myeloma, but it does create challenges in terms of disease monitoring, assessing efficacy of therapy and detecting progressive disease.
Interesting. So what you're saying is essentially when you're treating this entity of myeloma, you're as in the dark as the rest of us in the field of oncology are in terms of how our treatments are going and how to assess early relapse.
We're in the leukemia dark space of relying on bone marrow or imaging studies like the lymphoma doc. So yes, it does. It leaves us sort of relying on those other tools.
Right. So so this patient received daratumumab, bortezomib, dexamethasone, and had 9 cycles of therapy. Also had a bisphosphonate, and maybe I'll pause there for a second, Dr. Nuka. Can you tell us why bisphosphonate would be indicated in this case?
So bisphosphonates decrease the osteolytic activity. So that is the primary reason why they've become an integral part in treatment of any myeloma patients. So the osteoblastic activities is suppressed and the osteoclastic activity is significantly increased. And by using a bisphosphonate, we certainly can impede the osteoclastic activity and prevent the skeletal related events. And this has been confirmed in multiple clinical trials in the past, looking for the benefit with the bisphosphonates. And yes, those all have been shown to be positive trials, decreasing the risk of the SREs, and we certainly use these in almost every patient.
And so you initiate bisphosphonate after completion of your course of treatment in patients with bony involvement.
So in fact, that's a good question. So in my practice, I typically use a bisphosphonate in every single patient. So I use it for the first 2 years. So in the past, when we did not know the long-term toxicities of what could happen, we used to use it for much longer time. So, but the reason why we use them, even among patients who do not have a bone lesion, is they could have occurred disease that we are unable to assess.
Interesting. Okay, thanks for clarifying that. So this patient then completed palliative radiation therapy to the low back, and unfortunately has been wheelchair bound with worsening neuropathy. So not easy to get through these treatments for sure. So, it sounds from Dr. Forsberg's comments as if there's no real difference in his approach to a patient with non-secretory myeloma with respect to what treatment he would choose. And Dr. Nuka, is there any difference you have with that, or is that pretty much your opinion as well?
It's so the clone that has expanded is the one that is non-secretory, and you don't have a secretory disease. So I completely agree with Dr. Forsberg. We don't see anything different. The biggest challenge is we don't know what we're doing. We're shooting in the dark.
Mm-hmm. So going back to this patient, how would you have treated her at this sort of many years later disease progression?
So the choice of the treatment that was used is absolutely reasonable. So the patient has received daratumumab plus bortezomib and dexamethasone. This triplet combination has shown to be much superior than bortezomib and dexamethasone in the CASTOR trial. So it is a reasonable choice. So what I would have done additionally is every 3 or 4 months, get a PET scan and a bone marrow biopsy simultaneously to see if this is working or not, just purely for the purpose of preventing an end organ damage. Unfortunately, this patient had an end organ damage.
Mm-hmm. So I think that's, go ahead. Yeah, so I think that's a great segue to the second question with respect to the optimal way to perform response assessments here. I was joking a little bit before, but I think the myeloma field is uniquely advantaged by their sophisticated detection techniques and monitoring techniques, and so this is a case where you don't have those even in the setting of a myeloma, so you're forced to be back in the dark ages with us leukemia and lymphoma docs who are bone marrow biopsying and imaging at pretty regular frequencies to assess whether therapy is working and or whether it might be time to change.
Dr. Pillai, I think this is a good place to say that there are response criteria for FDG PET, and actually Dr. Nuka's group introduced us to those. And you'll be happy to know they're Deauville-like. They incorporate some of the visual criteria that Deauville use, and we put them in as in our template, report template.
So that's fantastic to know. So a PET scan can be more quantitative than ever before with those types of metrics. So that's great information. People, is that Dr. Nuka? That's assume a publication people could look up or look into?
So there is a publication that was available. I can't recall at the top of my mind, but there is a publication that is available. There are future techniques that are still not as mainstream as we would like to be. So in addition to what Dr. Schuster talked about, the PET scans, using the mass spectrometry for exactly people like this to measure the clone, as well as using the next generation sequencing to look for the clonal burden, is all in the pipelines, so that in the future years we potentially can use those in addition to what we're using today.
Oh, that's great to know. Okay. And then finally, I'll just ask Dr. Forsberg, this patient, performance status 3 in a wheelchair with significant chronic pain. Would this be somebody that would be an appropriate candidate for at least consideration of an autologous stem cell transplant?
I think it's, kind of a tricky, question to a degree. I think that certainly patients can have impaired ECOG status based around bony disease involvement and pain that may not be something that prevents autologous stem cell transplant from being a reasonable consideration. That said, it is an intensive procedure. It's an intensive therapy that requires months of recovery, and to go into it in a very compromised place may make that recovery really challenging. So, one thing we do know about autologous stem cell transplant in myeloma is that it's not necessarily a now or never consideration. If you have a patient who's in their 60 years old or in their early 60s, collection of stem cells at a time of remission would allow you for a stem cell transplant in the future. Maybe if a patient's able to improve their performance status through rehabilitation, better pain control, healing of bone disease, whether or not they need prophylactic orthopedic procedures to try to maintain mobility or gain it in the future. So I think that it may be a scenario where, I agree that you need sort of intensive monitoring approaches, coupling bone marrow and PET to try to understand your response circumstance. But it may also be one where thinking about collection of stem cells, but focusing on, improving performance status towards an idea maybe that a future transplant would be, sort of in the patient's best interest might be the route I would think, and for somebody who's dealing with some of the challenges this patient may be at this moment.
Great, thank you. So, it sounds like for a non-secretory myeloma, the disease biology is such that the same treatment regimens that we would consider for, the more standard myeloma would be applicable here. The major difference, as we've learned, is the challenges with respect to monitoring. And to do that, we will continue to rely on radiographic radiographic assessments and bone marrow biopsies with new ways to quantify the responses by PET and other, it sounds like, very exciting techniques coming down the pike too. And with respect to transplant, I think, what we heard is that, perhaps the degree to which her performance status is poor is thought to be because of her myeloma. Might be the way to decide how much she might benefit from an autologous stem cell transplant, whether that's now or in the near future, if she can get stronger and healthier.